Good afternoon. My name's Leanne Wells. I'm the CEO of the Consumers Health Forum of Australia. You're listening into, this is a second webinar we're hosting today with the Australian Institute of Health and Welfare to talk about and learn more about the National Primary Healthcare Data Asset that's in development. Our first webinar is available on our YouTube, where we talked about and drill down a little bit around the privacy and protection and consent issues in relation to the data asset. So have a look at that. But what we want to talk about today is the benefits of the National Primary Healthcare Data Asset that the AIHW has been charged to build by the government. The idea of a primary healthcare data asset comes at a really important time for primary care. It's interesting to know that despite the central role that primary care has in the system and the number of us who actually get most of our healthcare in primary healthcare and in the general practice setting in particular, that there's limited data available about the experience and the outcomes of primary care, what actually happens in that care setting. And that makes it difficult to assess the impact of the sector on the health of Australians, but also importantly, how we can use data and the opportunity to create more data to help us shape better policy and improvements in primary health care. So recognising that the federal government made funding available in the 2018 budget for the development of this primary healthcare data asset. So to learn more and to discuss the benefits of the data asset, I'm here with a panel today, so I'd like to introduce those to you now. We have Michael Frost, who joined us for our first webinar. Michael is the head of the Primary Healthcare Group at the AIHW. We have Jen Morris, who is a consumer advocate from Victoria. We have Elizabeth Carrigan, who is the CEO of the Australian Pain Management Association, a patient advocacy and support group. And we have Dr. Charlotte Hespe. She's chair of the New South Wales ACT branch of the AMA, of the RACGP, sorry, Rachel, Charlotte of the RACGP, associate professor at the University of Notre Dame and a practising GP here in Sydney. Just a bit of housekeeping. If you want to submit questions or a comment to the panel, you can do so online. Just use the blue hand icon, which is on the right-hand side at the top of your screen. And we encourage you, as we go through the conversation today, to take that opportunity. The idea of a primary healthcare data asset, it's a bit of a jargonistic term, a data asset. So let's start now looking at unpacking what we mean by that and hopefully get some good conversation going about benefits and some questions from you online. So, Michael, perhaps I can ask you in the first instance, can you tell us, going right back to day zero, where the idea of a national primary healthcare data asset came from in the first place? What was the driving force for it?
Well, from the Institute's point of view, our role is to produce reliable and robust information about the health and welfare of Australians and to improve those outcomes for all Australians. We summarise that in our strategic directions as an organisation as stronger evidence, better decisions, improved health and welfare. We work primarily in the stronger evidence place and we're hoping to inform the decisions of the public and consumers, clinicians, people who deliver services in health and welfare, planners and policymakers on ways in which they can then improve health and welfare. So this is an area that primary care makes up about 34% of all health expenditure in 2016-17, about $63.4 billion. But importantly, it's also the front line of the health service that everybody experiences. So that's where most people will engage with primary care. And so it's big, it's important, it's the thing that most people engage with. But as you mentioned, we don't know aside from a few different data sources that give us information about some things, we don't know a lot about what happens to people in primary care. What's their journey, what's their experience, why do they go and see a doctor or another primary healthcare practitioner, what happens when they do see them, what's the diagnosis, what actions are proposed, what's the result of those actions.
Because we do have quite a bit of information about hospitals, don't we? We've got the My
Yes, we do.
Hospital
Yes, we
website, so is it fair to say that that's the sort of information imbalance we're trying to correct here with this
Yes.
primary healthcare data
So we're taking
set?
the other really big part of the health sector and
Yes.
we're trying to fill the
Yeah.
gaps in that information,
Yeah.
the similar types of quality of information that we
Yeah.
have for hospitals. We want to have that in primary care as well.
Yeah, yeah. And of course our challenge there is that hospitals are state-run and government-run entities. There's a large part of primary care that is delivered by private providers. So part of the opportunity and the challenge we've got here is how do we get that data in a usable way from that sector. So thinking about, I'm a visual person, so if we thought about what the data asset might look like in a really practical sense, what will it look like? What do you think? What are we looking at?
Well, I guess it's probably important to set out at the outset that we're not talking about an individual health record.
Yeah.
We are talking about drawing data out of existing data sources that hold individual health records, like general practice software systems, for example. So the data asset would be something that is formed by drawing information out of these kinds of systems that already exists, but drawing specific information, not all of it, not the whole lot of it, but specific things about, as I mentioned before, diagnoses, prescriptions, be they prescriptions for drugs or prescriptions for some sort of action, and then what comes back later on as well. So trying to understand the information out of those systems. The data asset, we've used that term, and I know in the last webinar people said that was not a great term, and we'll try and think of a better name.
We're running a competition for a name, yes.
Really we've called it that because we didn't want to convey, at least at the outset, that what most people think of is a data set or a database, which is a singular thing. This is probably, given the nature of primary care, going to be several different things together. The data asset would then comprise both those bits of data that we have from various places, as well as the governance arrangements that we put around it and the access arrangements for those who have legitimate reasons and can go through the governance process to gain access to use that, be they researchers or government departments or policy planners.
And so you talked about the data asset being a composite and drawing in data from existing primary healthcare sources of data. Over time, is it the intention that the AIHW might also, and particularly in consultation with clinicians and the consumer community, make recommendations for other data gaps that we need to do something about in terms of collecting additional primary data from somewhere? Is that part of what we might be looking at here?
So in terms of primary care data, we are working through things that we've identified through our earlier consultation processes and our discovery process before that, identifying data sources that might fill some of the gaps. We do, over time, identify gaps. It's one of the roles that we have under the AIHW Act, particularly as part of the two reports that we deliver on alternate years, Australia's Health and Australia's Welfare, and in those we do generally identify where we go through all the different topics about the health sector or the welfare sector, and on those we would say, well, how can I find out more? What things don't we know? What are the data gaps? What's the AIHW doing to fill those where we have a role? So we do, over time, will identify gaps, but we've identified obviously primary healthcare and what happens in primary healthcare as a key data gap because of the significance of that sector and the need to understand pathways through the system, which generally, because of the nature of primary healthcare, start in primary healthcare.
So if I can ask then, I mean, if we're talking about the practical benefits of this, I mean, the government's obviously accepted the business case that we need a data asset like this. So this is a sort of triple-barreled question to you, and then we'll come to the rest of the panel in a minute. And we've got some questions coming in online already, so that's great. We'll get to those. If I'm, say, a GP, or if I'm a PHN, a primary health network, how will this data asset benefit me? How could I use it practically?
So our aim, I mean, obviously a general practice practitioner will know a lot about their own patients and possibly patients in a broader practice or in a broader area. We're aiming to build a data asset that gives robust, larger numbers that can tell you more about the population generally and how your patients compare to that broader population.
Right.
We, in parallel to working with consumers, we're also looking to work with clinicians to understand the particular benefits they might be after. And we're working on proof of concept projects that look at specific research, as we understand that it's probably easier to articulate in regard to a specific investigation some benefits that come from that, rather than talking in the abstract about the things that we know as data people, about population health, about pathways through the system and how do they look, and do your patients look like that as well? Is there something different that you could do to do quality improvement? We know from our consultations to date that quality improvement is something that clinicians in the primary care sector find very important, and they do want to see some benefits there from data. And that's one of the things that it can feed into, as well as improving, providing a premise for improved research in primary care that can also feed into that quality improvement cycle for clinicians and practices.
So, Charlotte, can I ask you to respond to that, just in terms of the utility to general practice of a new data asset like this, but what would GPs expect to see in this, and how would they expect it to be used?
That's a great question. Thanks, Leanne. In terms of the GP, I think it would be fair to say that a lot of GPs don't actually know what it might do for them at this point in time, because we've never had it. We've never had an ability to really understand the differences between what my practice might be doing versus a practice across the other side of the country that might have a similar socio-demographic, or even another practice in the same city or in an rural setting. We get told lots of things about it, and we've used information in the past from Sydney Uni, did a thing called the Beach Study, which was a fantastic photograph of general practice in Australia, because each GP who participated gave 100 consecutive patients. It was a paper recorded session where you just wrote down what happened, how long was the patient seen, and what things happened. So Beach gave a great sort of snapshot of the sorts of problems, how complex they were, how long patients were seen for, etc. But there was no real other system that GPs have been able to do. For me, one of the big aha moments as a GP was when I started doing quality improvement, which was through a thing called the Collaboratives project and the Australian Primary Care Collaboratives program, where practices from around Australia got to talk together. They all had goals. So, for instance, we looked at improving the care of our diabetic patients. And there were these measures that we all had to answer to. And through that, we started to get data, not just about our own practice, but also about other practices doing the same project. And it was extraordinarily eye-opening to me, that real, as I say, aha moment when it was like, wow, I don't do as well as I thought I was doing, and why not? But also to see what other practices were doing and what solutions everybody had to actually work together on improving it. It was fantastic, because by saying, how are you managing to do that? How do you manage to have so many of your patients who are reaching that goal where this practice isn't? What are we doing differently? And through that, you can actually start coming up with localised solutions that actually can really target patient care better. Because I think we get stuck as a GP looking sometimes just at the patient in front of me. There's nothing wrong with the patient in front of me, because that's my absolute bread and butter, that's the thing I do and I need to do really well. But to be able to look after the patient in front of me better, I need to understand how that fits into the entirety of what I do. So I like it, somebody used to use an image and I didn't quite get it in the first place, but it was about thinking of me looking after the cows. So I was a farmer, so I had a herd of cows. So I obviously wanted the cow to be really healthy, but I didn't just want the cow to be healthy, I needed the whole herd to be healthy. But in order to understand why my herd was healthy, I needed to understand my pasture, the grass, the environment, and how that all meant. And then by comparing it with everybody else, I could actually really start to make every single individual cow that much healthier because I understood the entire context.
Thanks, Charlotte. Jen, as a consumer advocate, I imagine and I hope that's music to your ears to hear that clinicians have a real appetite and an interest in working with data to improve their services and to know their patient population better. It's all about improvement and data-driven quality improvement, as Charlotte was describing. From a consumer perspective, what do you see the key advantages of a data asset like this?
Yeah, I think Charlotte's really well articulated that kind of clinical role for this, so I won't try and do better than Charlotte has done. So I completely agree with what Charlotte said about the role that at an individual clinician level, being informed and empowered by that comparator information and that context information will improve the care of each of those individuals and of everybody together. So I want to talk about, I guess, something else that from a consumer perspective is really important, and that's at that wider system, that wider society level, where I would compare the advantages of this to the advantage of the census. So we all do the census. None of us necessarily individually is getting individual feedback and individual changes in our lives specific to us on the basis of having done that census. But what happens is we all contribute our little bit, and those little bits paint a picture, and that picture can tell all of the people in healthcare, all of the people overseeing healthcare, policymakers, researchers, people who are making laws, monitoring, planning the system and the services, where the gaps are, where things are being done really well. So as Charlotte said, you can learn from that as much as identifying those gaps and service gaps, as well as, I guess, gaps in access. And I think one of the most important things for me that this system will do is allow us to really add evidence to something we all know that's going on, which is issues around variations in care, issues around inequity, issues around uneven patterns of use and patterns of access. We all know that that's an issue, but to be able to have the granular evidence on exactly for whom that's an issue and exactly where. So I think it's really important to creating a more equitable system and to ensuring that the limited resources we have are used in a way that is evidence-based, that meets the needs. And what this does is allow every Australian who is part of it to do their bit, just as they do with the census, to add to that picture. And so to give a concrete example of what that might look like, and just a generic example would be that if we were looking at this data once we've got it together and we see that in a particular area that the proportion of the population who has a particular demographic feature is much greater than the proportion of people with that feature who are using a preventative health service, and that causes us to ask questions about why is that the case? Why is there an access gap there? Why is there a usage gap there? So I think it gives us information about the usage of the system, the who, the what, the where, and the by with who to some extent. We can only then draw the why through, I guess, wider thinking and some speculation, but it does help to inform the why. And for consumers, I think that's the great value in this system.
I might just go to a comment and a question we've got coming in online as well from Paul, and he asks and says, to be really effective, the data asset needs to record all the situations where people don't get solutions to their problems.
Correct.
And there's obviously, there's solutions to your presenting problems clinically, but there's also the problems or the deficits in the system where there's always room for improvement around access and equity and where we're investing in the health dollar. So his question is it going to do that? Help us identify the situations where people don't get solutions to their problems. I think we can think about that question at the individual level and the system level. And if not, why not? So maybe, Elizabeth, you're nodding there. Have you got a thought on that?
Well, yes, I had the same sort of thought. Is it going to sort of pick up those gaps? I've been asked to talk about a specific cohort, and that is people living with chronic pain. And we've got about 20% of the population now of people with chronic pain, often elderly, but, a third of those people are disabled by it. So it'll be fantastic if the new data set can pick up a lot of sort of the evidence around what's working, but also what's not for people with chronic pain. I mean, we know that, I think now that people with chronic pain have been overly reliant on medication, and that's had significant problems for them and the broader society. But I think because we've already got that data, GPs and other health practitioners are now really working on that problem because they know it exists. But we don't know what's happening to that cohort of people that have been deprescribed. And we don't know what's happening to that cohort of people with chronic pain that don't have any medications. So I think in terms of that question and where the gaps are, that's, you know, an example of that.
Jen?
Yeah, I think one of the things I would add too, one of the challenges for this system, I agree with the person who's asked the question. I think one of the other challenges for this system will be how to deal with the significant burden of diagnostic issues that people will face in the healthcare system. So if we have a data system that draws largely on a drop-down box or an enter a code box for somebody's diagnosis, there's a very large proportion of people out there at any one time, and actually most of us in our lifetime, who will be either pre-diagnosis or without diagnosis, or with a rare diagnosis, or incorrectly diagnosed. And it's a challenge to find a system that will track that process, because sometimes a diagnostic error might be 2 hours long if you're in a hospital. But in a primary care context, sometimes those diagnostic issues are 10, 20, 30 years long. They have a very long legacy. There are conditions in Australia that still have average diagnosis times of 20 or 30 years. And what I would love to see, and I'm not the technical one who's going to work out how to do this, but a way to track when someone is finally diagnosed with condition X, to be able to look back at the incorrect diagnoses, the erroneous diagnoses they had before, and start to see the patterns in that and say, oh, okay, so regularly people with this condition, we now know, you know, were previously incorrectly diagnosed with this. The power of that as a problem solver for the people who have trouble with getting answers for their issues would be huge. But it's also a challenge to work out how to do it, because there'll be a primary care and hospital interface with that problem. It's a wicked problem, but an important one, I think.
I think the other thing to think about too, and this is your day-to-day life, I'm sure, Charlotte, is what is being managed in primary care now is, if not comorbidity, certainly multimorbidity more and more these days, when people have got 2 or more chronic conditions. So what do we need for that? We need team-based multidisciplinary care. This speaks to Roz's question here online about, will there be data collected on the work of general practice and other primary health care providers such as nurses, as well as allied health, or will it be doctor-centric? So I guess it's a question to you, Michael, about how are we defining primary health care data? Is it just about general practice or broader? And where's the starting point for the data asset build?
So for us, the data is intended to be not just general practice data, but also covering other parts of the primary care sector, allied health such as optometry, nurses, physio, psychology, and other parts of that sector, as well as community health. Our aim is to build a data asset that has data across the sector, and I think that. Just going back to Paul's question as well, so these are both good questions from Roz and from Paul.
Yeah.
Those questions about the people whose needs aren't being met in some fashion, we can look at those a number of different ways, and I think that's very important. It's something that we do with our existing data sets. In terms of those who aren't getting access to the system, we're talking, as I said at the outset, about drawing from existing data within the primary care sector, data that's being created by the general practitioners and other practitioners in the sector. So by definition, that's the people who got access, but by comparison to the broader population, we can understand some people who are missing out. That's one way in which we can look at some gaps. Another way is it would be possible, if we build a linkable data set over time, which is our intent, to bring together other data sets that make sense of that information, to say this could be hospitals data, it could be MBS or PBS data, and to say this is what people who had this rare diagnosis look like beforehand, you know, the period beforehand. Now, obviously, we're only building it now, so if it's something that takes 30 years, then it's going to take a long time before that shows up, but there are things that are much quicker than that, obviously, and our aim would be to build something that could be usable over time to answer some of those sorts of questions. And so I think the importance of that then, as going back to Roz's question, is that it needs to cover the field to fully understand that. The richer the data, the more likely it is that you can pick up some of those things and to say they didn't just show up at a general practitioner, they showed up at a hospital, they showed up here or there.
The whole patient journey issue, Charlotte.
From my perspective, there's a couple of issues there. I mean, there's no doubt that this data is going to help answer some of those questions. But again, you have to make sure that you're using the right data and not the incorrect data. One of the things from my perspective is you are limited by the data being in the right box. Like you said, you have to have a codable something to get that code. And in fact, the richer the source of the data in terms of if you're using the uncoded data, which is very rich, unfortunately, that then has these risks in that you can be much more likely to identify the source of the data. So there's lots of securities around trying to make sure that we don't make the data set too rich so you can't identify people, but at the same time then you're offset by you're not actually going to be able to have as much information there potentially. There's a huge number of tools coming out that are actually able to, I think, enable the use of the richness of the data without being identifiable and then putting it in. That's that whole AI type role and being able to then go back and pull data out. And there's some programs that I've seen as a researcher which are amazing that can start to, even looking at a 30-year problem, actually be very, very quick at actually picking it up much sooner using the data. But can I just quickly go to the linking? Because for me, that is where we're really going to tell a story that will help us understand our healthcare system. I'm very passionate about the knowledge that a system will deliver what a system is designed to deliver. Our healthcare system is a beautiful system, but it was designed in the 60s and 70s. And so it delivered beautifully for what was needed in the 60s and 70s. And as Leanne has already alluded to, we are not a society of single medical issue problems. I'm always delighted if I have someone who's got one problem to manage because for me, that's just easy. The vast majority of the people I look after are very complex, multimorbidity with multiple medications and lots of social issues that we're trying to do the navigation around the understanding of what then is the best care for the person in front of me, which may need to mean that there are certain bits that aren't managed nearly as well as they might be if they were the single problem. And so we really need data linkage to be able to help us understand that in order to, because what I'd like us to do is actually have an ability to deliver value-based care. Value-based care is about the care being the best care for that person at a cost that is actually affordable to us as a country. And our current system is a volume-based system. It values me putting lots of things through. It doesn't value me doing a really good job with the person in front of me. And until we get the data like this, we can't show that story. We can't have an understanding of what goes on. New South Wales Health has been doing some really lovely work with data linkage, which has shown that a patient who has continuity of care in general practice, who may be seen more times than people might think is good, actually costs the entire system a fraction of the amount of someone who is not getting that same continuity of care and multiple visits because, I mean, it makes complete sense to me. Their entire needs are not being met properly and we've actually got to show that story with the data, and I think we can once we have a data asset, but we do need to link it to hospitalisations and to the rest of the system, including all the allied health.
So I want to come to Elizabeth and Jen then, and I know you've got something to say there, Elizabeth, but I think what that draws out is, is the community ready? Given the recent debate about my health record and doubts expressed by some about privacy and security issues there, are we ready as a community? Do you think Australians are generally aware of the potential benefits available through de-identified health data generally, let alone linked data? That's the first question. And then the second one is, and you've all alluded to this in various ways, we call it social licence. We want systems like this to have a social licence, you know, social imprimatur behind them, because they are an asset, and that's why it's been called an asset. So the first question then is, are we ready as a community to Jen and Elizabeth? And then the second one is, what steps should we take? If the answer to that question is, well, you know, that'll be variable. There'll be some who understand. There are those that are going to be sceptics. It's the classic bell curve. What do we need to do to educate the public that an asset like this is in our national interest and in the interest of a better health system?
I'm not sure, Leanne, whether people are ready or not. I doubt that. If you ask that question now, I don't think many people would say yes. But if you explain the story, and I think stories are really important to show people exactly what the benefits could be of having de-identified data, and to build that clinically and show that, you know, if you have that data and evidence, how that can improve the healthcare system, then I think that, you know, you start to change people's minds. You know, that'd be my hope. And then I think it needs a really big public campaign around it, you know, led by, you know, organisations that are, you know, leading consumer organisations, of course, like CHF, but also clinical organisations have got to be in that picture.
Leanne, I think I agree with Elizabeth. I think the answer in general is, to the question, are we ready? Do we have the need? In that sense, we're ready. Do we have the sentiment to get away with this without people getting, I guess, disquieted by some of those questions about privacy, etc.? I don't think we're there yet. I think what's important is a really frank and honest and open discussion with both consumer representatives who are intensively involved in this process, but then with the public more generally, to draw a distinction between the proposed and hoped for benefits of this versus the My Health record. Everyone out there has very busy, complicated lives. They've got information coming at them from all places about everything, about the weather, about politics, about workplace, about everything. And so it's easy for things to blur in our minds. And I think it's very important that we understand there's a difference in narrative between the way My Health record needed to be talked about and needs to ongoingly be talked about and this asset. There's a risk that people will hear my data and something and conflate the two. And what is the important distinction is that My Health record's proposed benefits, and in theory its benefit is to individual people and their clinical journey and their experiences as a person. So in theory, when they're taking on the risk that some people will see of being in there and the security risk that comes with that, taking on that risk comes with a direct personal benefit in theory. So that's a different calculation. This calculation is about largely still taking on that risk, because we can't deny that is there, for not so much a personal benefit or a personal clinical journey benefit, but this wider kind of greater good sort of benefit. So I can understand why people would feel differently about that calculation, and we need to be honest about that. I think we need to be open about that. And to remember that, you know, there's a lot of questions that might be asked about how do we get people to trust? And I think the right question is not how do we be trusted, but how do we be trustworthy? And there's a lot of work that needs to go into that, because if you're trustworthy, the trust will follow. And I think that is the correct order in which to do things. But there's a lot of work that will need to be done. And we have to recognise the reality that the large proportion of Australians, no matter how much we do the education and the public campaigns, which we absolutely must do, but no matter how much we do that, who won't know anything about it, who won't have heard of it, missed the ads, didn't engage with it. Mm-hmm. So because of that, we can't rely on, well, we told everyone in some TV ads, so it's okay. We need to have a system that's fundamentally okay, fundamentally good quality, fundamentally ethical, regardless of that, because not everyone will know, and it has to be inherently trustworthy.
Can I intervene too at that point? Because I think that we not only need to take the consumers along, we also need to take the doctors along. Yeah. And there is a huge amount of paranoia out there about the collective data and how it's going to be used by a government agency and what is the underlying objective, and, you know, paranoia about, you know, if I'm going to be penalised because I'm not doing as well as the practice next door, and, you know, you're going to destroy my business, or that sort of whole accountability, which to me, as I sort of put forward, I found it extraordinarily refreshing to be able to improve what I'm doing. But that's where the story's got to be around. This is about improving everybody's health, everybody's access, and the equitable nature of the healthcare system that we're doing. This is not about being punitive. It's not about going and finding an individual and saying, you know, oh, I know about you. This is very much big picture, need to really be accountable to deliver the best healthcare that we can to everybody in this country.
And I've got a couple more questions here, and I'll come to you in a moment, Michael, for a response to that. But I think that's an important point, and that's why, without putting words in your mouth, Michael, about why the AIHW is very aware of the need to create conversation around this take a co-design approach, generate a social licence, because it's being developed and conceived of in that wider environment of just generally, doesn't matter whether you're a doctor or a member of the public, there's this general distrust in anything institution, and you know, that's this sort of operating environment. So you might want to comment on that, Michael, and then we'll come to another couple of questions that we've got here online.
Yeah, I mean, I think they're both very important points. That's partly why we're having these discussions now, is we're trying to work down that path of developing community trust in what we're doing by being transparent about it. This is what we intend to do. We do intend to bring together primary care data from systems that are out in that sector. We want people to know that and understand what that means. And so it's that openness is the starting point for trying to build that trust, and it's not immediate and it has to be ongoing. So we are committed to doing that. The other thing is that we do have to get a lot better at talking about the benefits of the data, not just for primary care, but across everything that we do. We are starting to put a lot more effort into articulating that benefit about some of our bits of work that we've done. We've got some good examples in, for example, demonstrating the better results from people who've had their cancer diagnosed via screening rather than via symptoms presenting and them seeing their doctor. We're starting to see that kind of information. That's based on a data linkage and then working it out what the results are over time. So those are important things that we need to go through. In terms then of, as well, we need to develop that trust by showing people the things that we won't do. And AIHW obviously is bound, like any other Commonwealth entity, by the Privacy Act. We're also bound by our own Australian Institute of Health and Welfare Act, which provides some additional protections in terms of confidentiality. We can't release identifiable data except in certain circumstances that are provided for by the Act, but also provided for by the agreements that we have with the data providers that give that data to us. So obviously this is going to be a process of us negotiating with data providers in the sector. That coverage includes not only individuals, importantly, that the data is about, but also individual providers. So we wouldn't be able to provide information to people for the purposes of enforcement, except in very limited circumstances where that was agreed with them in advance, essentially. So we aren't able to identify providers either, as well as the individuals in the data. So some of those things, it really is about what you said, stepping up into the big picture and providing data that can be used for that systematic analysis to improve the system, improve planning, improve resource allocation, and also to inform continuous improvement in the sector itself, the things that we know from our discussions with clinicians to date that they really value, and we want to be able to supply information that can help them with that.
Thank you. And that whole issue of transparency and accountability, again, is part of our broader environment as well, and just, you know, consumers in the community and all sorts of players in the system demanding that more so. A question from Mark. Who will gather, and I think it's back to some of the points you were making in terms of the benefit to clinicians in service improvement, Charlotte, who will gather and put in place actions to address problems and disparity of care? For example, evidence that some doctors may be using older methods of care which have been which have become outdated?
Well, that's again a great question.
Yeah.
The way that the government has sort of put it together is that the primary health networks have been primarily tasked with the quality improvement role and in terms of the initial data custodian. So the way I see it at this point in time, the primary health networks are probably the best placed in that they've got relationship with all of their primary care providers, and they will get reports on what's happening, and then it's about, well, how do we address it? How do we see that there is a gap in our community of equitable access to people who don't speak English as a first language, for instance, and who are, being diagnosed with cervical cancer. So how do we then redesign or ensure access for that particular population? So I think that can be done in that way. There may well be that it's a particular practice that's not, isn't being able to deliver, and so it's about going and asking the question, well, why do we think that is? Is it because they're overwhelmed by, another health need and therefore they're prioritising down? And so do we need to make sure those services are there? I mean, there's lots of solutions, but yes, I think the primary health networks have been given that task. Can I say the responsibility then of government is to make sure they actually fund the primary health networks to be able to deliver on that task? Because it's no good telling somebody this is your job if you don't actually give them an ability to do the job with, whatever resources that might look like. And I think a lot of that can be shared amongst the sort of the healthcare system. But, if we continue to say, well, all the money's got to go into the hospital, but in fact, the services that I need to solve this problem are actually community services, then we do actually have to have that hard conversation about I need to move those funds across. And at the moment, I haven't seen that happen.
You mentioned value-based healthcare and the notion of that before.
Yep. And so it is going to be, there's going to be some difficult funding implications, and I don't think we should do it slowly. The way I've seen it work overseas is you actually enable everybody, and then as you enable, you're able to then cut the costs where they're no longer needed, rather than removing them from somewhere where they're already where they're still needed, but expecting another part to pick it up without actually funding them. So sometimes it looks more expensive to start with because you've got to enable other bits, but in the enabling you can actually then really bring about the cost benefits.
Okay, just for our viewers online, just a reminder, if you want to submit a question or make a comment, we've got plenty coming in here to the panel. Use the blue hand icon at the top right-hand corner of your screen. We've got another question here. I think we've covered this in part, but let's elaborate on it a little bit. Who will be the users of the data asset? And are you asking them what information they need? What are they saying?
Well, that's part of the discussions that we have to have, and that's what I've alluded to in terms of talking to clinicians about what is it that they value. We are presently working through a number of different what we're calling proof of concept projects to show how it could work, and that's touching on different elements of what we might do, such as how would data extraction work, where would we get it from, but also would then ask, well, what are the questions we're going to ask of the data, because that's a very important part. Now, that will also happen with the research community. There'll be others who are interested in looking at data once it's available, and as well as, we do a lot of work ourselves. People would be familiar potentially with AIHW reporting, so we would look to report high-level information out of this as well that generally informs the public. But we have established arrangements for people to come and seek access to data that we hold, where the data is held on the basis that we would be providing access. So this would be one that we're aiming to do, is to provide it potentially to PHNs, to researchers, to clinicians, potentially to government departments, and potentially for our own internal work. When we do that, we ourselves go through, we have an ethics committee, an independent ethics committee that supports the AIHW, and to which we put a lot of our work with data. Again, we do that with our own internal work as well as for people who are coming externally to seek access. That's another one of the strengths of our arrangements in terms of access, that people can can rest assured at least that it is getting ethical oversight, that we're not doing things that are outside the terms of what people have provided us data to do, and that we're doing things that are in line with community expectations.
And that ethical oversight's another important ingredient in transparency and trust. Can I come back to both Elizabeth and Jen and ask you a question about how important, from your perspective, it will be for this data asset to capture information about patient-reported experience measures and patient-reported outcome measures? Because it's back to your point too, Charlotte, about we talk about value-based healthcare, you know, from the taxpayer and from the government point of view. We don't want Medicare benefits being paid for redundant services or interventions that aren't evidence-based. But part of that value equation is also what matters and what's going to make a difference to patients. So it's the medical intervention and getting something that's appropriate and evidence-based, but it's combined with, that's what primary care is all about, isn't it? You know, it's whole person care. It's those other pieces of advice or social prescriptions we talked about earlier before we went online, coming into the equation as well. So PREMs and PROMs, as they're known, about how important are they and how important is it that we capture that information in this from both of your perspectives?
Yeah, I think enormously. I think for two reasons. I think it's part of the sort of social contract, social licensing that you're talking about, Leanne, to say to people, look, we're asking this of you, because we are asking Australians something, we're asking something of people to be part of this, and he's saying, we're asking this of you in terms of some kind of objective data about yourself, and that's important and that's great. But in the end, back to that question of what is the purpose of this, and the purpose of this fundamentally is to improve the health and healthcare for Australians. And part of health and healthcare outcomes is, in essence, is this right for the patient? Has it achieved what they wanted? Is it in line with their goals, their values, their cultural preferences and all of those things? And I think one of the risks of a system like this, and lots of other things we're doing in healthcare at the moment, is to create and enforce and reinforce quite narrow, condition-specific, prescribed pathways. You know, if you have type 2 diabetes, this is how it shall be done. And that's how we're going to measure the quality of care. And there's some merit to mapping pathways, of course there is, but we need to have this ability to say, okay, for 90% of people, that evidence-based approach is correct, but for someone with this cultural situation or this family situation or this other comorbidity that doesn't nicely fit the pathway for the single condition, which is for most people a big issue, comorbidities, that we have the ability to say in these records, in this data, so yeah, well, you ticked the boxes of the pathway, but fundamentally, did this make your life better? Did it improve your health? Did it meet the goals that you have set for your care and that you and your provider set for your care? So I don't think we can do this right without doing that, because it goes back to what I said before about this data can give us a bit of the what and the where and the when and the how, but it can't really tell us the why without that kind of patient input about why didn't that service work for you, why did it, what's working, what's not working, and is it achieving the goals? Because I think it's a danger for us to, as a system, to decide for ourselves, looking at a list of events that happened, yes, that is right, tick, you know, that's good care for that person, without some kind of input from them. So I think it's crucial.
Elizabeth, from your perspective as a patient advocate?
Yes, and I think, you know, we see a lot of people coming through helplines and support groups, and we know that people are getting stuck in primary health care and they're not rehabilitating, their chronic pain's not getting less, they're not improving, I think, as they could be, and that's often because that best practice healthcare is just not there. Some things are working well, like I think GPs are utilising the chronic disease management plans really well for people with chronic pain. But in regional Australia, allied health, there's a big shortage. So people can't get to the allied health, or it's really expensive. So I think, you know, those resources that the GPs are utilising might not be working as well as it could be. And I think, you know, hopefully this data set will, you know, pick those things up. I guess another example is around the medication. As I said before, we've got that data, but for people who are not getting medication, are they getting other evidence-based choices and options that'll help, or aren't they? So I think, you know, it'd be lovely to get those answers, I think.
Yes.
So
Can I,
Charlotte?
Yeah, if I could build on that too, to actually also add in the doctors, because I'm fascinated by understanding why doctors might not prescribe according to best practice as well. And sometimes that is informed by, you know, that somebody doesn't want to take a medication, doesn't want to increase the dose, doesn't want to, you know, do X, Y, or Z. And we do, you know, we have that whole conversation around what is therefore the best choice for you. And we can probably try and, I think, sometimes pull that out a little bit more and have a richer understanding of what happens there, which may actually pull out that there are doctors who are biased against using a particular treatment because of a previous experience themselves. I mean, we all know the trial of N=1 is a very powerful thing for everybody. And, you know, if a doctor's had an experience where a patient died of the side effect of a particular medication, they are highly unlikely to be offering that as an option or push that option as something that would be good, because their own personal experience for another patient has been tainted. And being able to understand that and the whys and the wherefores, you know, it can be sometimes more complex than just the, you know, and we might sell it in a way that is biased by our own picture of that. And the same with, you know, I get patients who come to me and they're absolutely adamant because their family members have told them this is what you must do and this is the course of treatment you must access, without fully understanding that there may actually be another picture and another scenario that they need to consider.
So it's complex and nuanced. So to you, Michael, then, you know, we're hearing that the whole patient-reported experience, GP-reported experience for that matter, in that sense, both in terms of patient-reported outcome, what matters to them, patient-reported experience. How will that sort of data and can it be incorporated into the data asset?
So in terms of the, I think I'll start with the GP experience or the practitioner experience if we're looking at other sectors as well. That will be in the record to the degree to which the GP or the practitioner is recording it in their systems as they stand. So the question is then, that goes to what parts we extract.
Systematized.
Yeah, and is it that systematized information?
Yeah.
But in time, in fact, we are looking, as you say, there are tools that could potentially look at what we call unstructured data that's not in fields like that. The first challenge for us is limitations on, you know, potentially identifiable information in unstructured data. But we're working through some of these things as ways to extract that information without extracting identifiers, but then also ways to systematise the information automatically. So that is potentially there because it's a GP record that we're drawing on, or because it's, you know, a physio record or whatever other record we might draw on in time.
But with all the protections and privacy provisions and all of those sorts of things top of mind as well.
And then in terms of patient-reported experience measures or patient-reported outcome measures, again, that would depend on the degree to which they are collected. We know that some practices do have add-ons or separate standalone software that does that as part of their process. So if that information is collected and then also is part of the patient's record, then that's something we could potentially get access to. Failing that, there's other channels. There are surveys that can be run on patient-reported experience and outcome measures. There's various validated instruments for doing that. The question would be, in that circumstance, you know, at some basic level, if it's not linkable, we can sit the surveys by geographic or some other demographic information and say, this is how this group looks in the GP record and this is how they look in the survey. But alternatively, if you do have linkable surveys, then you could subsequently bring them together. But we know that some sections of primary care are already using ways of collecting that information. And so if that's part of their records, then potentially that's something we could bring into the asset as well.
Okay.
And we know there's a lot of interest across the board in that.
All right, and just to thank you very much. It's good to know that that's part of the broad horizon thinking with the data asset. I think just a clarifying question here, I think it was back to the question about who are the users of the data asset or the potential users. Paul's asked, so it's not envisaged that patient condition groups will have access to the data at the moment. Why not? When will they be aware of many patient needs that are being missed? So I think that's probably a misinterpretation from Paul, is it not? Because once this data asset is available and accessible, the patient advocacy groups like Elizabeth's, for example,
Well, that's what you'd hope.
You would. That's envisaged.
Yeah, there'll be an ethical process of
Yeah.
accessing the data.
We will have a process that we need to set up that respects the terms under which we hold the data, and then has to go through the requirements of our Act as well, and so that might involve, in certain circumstances, ethics consideration. But anyone who can go through that process and who meets the requirements put on us by data providers and by our Act, that's possible. So I'm sorry, when I use terms like researchers, maybe people think universities, but it can also be researchers from patient and advocacy organisations.
Yeah, great. It was good to have that clarified. Look, we've got about 3 minutes to go. I will just check. I think we've answered all our questions from online. There's one here that might be worth picking up on. It's sort of attribution, I suppose. Ros asks, drilling down, an example is vaccination, which is mostly provided by nurses in general practices, but attributed to GPs. How will the primary care data asset be able to identify the work of general practice nurses? Are we going to get that granular?
Well, can I,
and do we need to
as a
worry about
GP,
that?
can I answer that?
Yeah.
In GP software, you actually do record who delivers the vaccination. So, and that actually
So it's extractable.
So that's extractable, yes.
Yeah.
So you can actually do a really nice body of work saying, well, is that assumption correct?
Yeah.
Is it actually being done more by nurses than GPs? One would expect so, but in fact, you know, so far we still don't have 100% of general practices having practice nurses, so there's still an awful lot that don't get done by practice nurses, and or if the practice nurse isn't there. So how many are being done by practice nurses, and could we actually improve the number being given by practice nurses in order to sort of increase access for the GP for another task that they don't necessarily need to do?
Exactly. Yeah.
And pharmacists with the flu shots.
Well, that's again is already, you're able to see how many are being done in pharmacy because, again, they have to upload to the immunisation record. So.
Sorry, Michael, did you...
I was just going to add, there's growing delivery of immunisations in vaccinations in other settings as well, pharmacy. Many of the vaccines are delivered in schools, again, by nurses, but there is the Australian Immunisation Register that collects those, so we'd be able to refer to both that and potentially to what information is stored in general practice systems as well, to understand. And if it does collect who delivers it within the practice, then that's, as you say, it's an extractable record.
Okay, all right. Well, thank you so much to the panel, to Michael, Jen, Elizabeth and Charlotte. Thank you for your questions online. Can I just close by asking you, Michael, if people out there listening into this either now or when we put it on our YouTube, if they want to keep track of developments with the primary healthcare asset or want to get involved, how do they do that? So
we have on our website, if you go to the AIHW.gov.au website and look at the primary healthcare page, you'll see what information we do have on primary healthcare, but you'll also see a page there about primary healthcare data development, at which point there's a link to subscribe to our email newsletter. We'll also periodically put updates there about what's happening, and when we do have data and produce reports, that will go there too. Terrific. Well, we certainly look forward to its development. It really is an asset that is going to fill a system knowledge gap in our system. So I think it's commendable, and we've certainly indicated that in our commentary around this at CHF that the government's chosen to invest in this asset. So thank you very much to the panel again and to listening in online.